everyone. Myself is Dr. Rajesh Kumar Jha, and I am an interventional cardiologist in Artemis Heart Center, Raj Hospital, Main Road, Ranchi. So I'm going to discuss some latest update on hypertension. So most welcome to everyone. We know earlier the majority of the death in India was due to the communicable disease, but now the 63% of the total death in India is due to the non-communicable disease, and of which the around 27% is due to the cardiovascular disease. We know the cardiovascular disease is affecting around 45% of the population in between the age of 40 to 69 year of the age. That means the most of the people who are suffering from the cardiovascular disease, it occur in between the age group of 40 to 69. That is 10 years earlier than the Western population. And the increased blood pressure is among the most important risk factor for the cardiovascular disease. And it remains very poorly controlled due to the low awareness about the hypertension, lack of the appropriate care, and also the hesitancy from the patient part that once they will start the anti-hypertensive medication, they will have to continue for lifelong. And these are the main hurdle in the treatment and the continuation of the treatment in the hypertension. So in India, the prevalence has gone over the 30 year to 38% in the men and 32% in the women. That means the total percentage of hypertension patient has increased. Even in the rural population also, it has increased many-fold compared to the 10-year-old data. So the over 62% of the men and the more than 53% of the women living in the hypertension did not get the treatment. And that is the very big fact. And that is the only cause for the cardiovascular death as well as the stroke, because of the under controlled and not adherent to the medication for the hypertension. And the medication was used to control the blood pressure in fewer than 1 in 5 men and 1 in 4 women with hypertension worldwide. So that is again a very big fact. That means the 20% of the hypertensive population is only taking the medication, and rest they are not taking any medicine for hypertension. Now, if you'll see the ISS data, that is the International Society of Hypertension, that has released and that address the issue that in the resource poor setting, the optimal care refers to the evidence-based standard of care, and whereas the essential standard refer to the minimum standard of care to allow the specification. Now, if you'll see the American Heart Association data 2021 that offered the new guideline for the management of stage 1 hypertension among the patient with low atherosclerotic cardiovascular disease risk. Among low risk adult, that means that there is no any cardiac disease, that is atherosclerotic cardiovascular disease, and with the stage 1 hypertension, that is the blood pressure in between 130 to 139 systolic and 80 to 89 diastolic, and the management start with the non-pharmacological therapy. That means the lifestyle modification, and blood pressure remains uncontrolled at 3 to 6 months, then the medication should be started. So that means the lifestyle modification should be advised earlier in the stage 1 hypertension, and after follow-up for the 3 to 6 months, if the blood pressure remains in between the 130 to 139 and 80 to 89, then the pharmacological therapy should be started. Now, the ARDS, that is the acute respiratory distress syndrome, is a potential fatal condition that involves the lung damage and expert often associated with the severe COVID-19. In a recent study, and it shows that the metoprolol can reduce the lung inflammation and the improved respiratory function in people with the COVID-19 induced ARDS. So lowering systolic blood pressure targets down to the 110 to less than 130 millimeter Hg range substantially reduced cardiovascular adverse event in the STEP randomized trial, affirming the sprint finding for an older Chinese population. So among some 8,500 patients aged between the age 60 to 80 in China, the intensive target trimmed 26% of the composite cardiovascular risk. And so the blood pressure, the criteria had changed And so the guideline says that the blood pressure, systolic blood pressure, should be in between the 130 millimeter of Hg, and that has reduced the cardiovascular death in that patient and also the risk factor. With regard to the prognostic value of the ambulatory blood pressure monitoring and the nighttime blood pressure, the 2018 European guideline on the management of arterial hypertension recommend that the diagnosis of hypertension should not only be dependent on the office blood pressure, but out of office blood pressure measurement, that is the home blood pressure monitoring or the ambulatory blood pressure monitoring, that is the 24-hour and nighttime blood pressure management were associated with a greater risk of mortality and composite of cardiovascular outcome. Also, for every 20 by 10 millimeter of Hg increment on blood pressure measurement at night, the risk of mortality increased by 23%. And that's why if any patient is having blood pressure and sometimes we found that it is normal, we must advise for the ambulatory blood pressure management or home blood pressure monitoring, especially at the night, just to see there is increase or the night dip is present, and that actually gives the estimate the cardiovascular risk in those patients. Again, in 2018, European guidelines recommend that in the context of the lower BP target to start antihypertensive therapy with an initial dual fixed dose combination of AC inhibitor or ARB plus CCB or diuretic. So the new concept has came for the combination therapy, so that the two multiple pathway medicine which will work at the two multiple pathway that will work, and that will give us a good control of the blood pressure rather using a single drug with the maximum dose. Since early July 2018, products containing the valsartan has been recalled worldwide. The reason is the detection of a known carcinogen. NDMA. NDMA has been classified by the WHO International Agency for Research on Cancer to be the carcinogenic in human. The presence of NDMA in drugs could lead to the 8 additional cancer risk. Valsartan recall accompanied by a significant increase in the rate of emergency department visit of plus 6%. That has very significant that was. The HYGEA study represents the largest study that tested nighttime antihypertensive treatment. In this trial, chronotherapy was associated with a significant reduction in the endpoint. The HYGEA chronotherapy trial tested whether the nighttime therapy in comparison to usual upon awakening hypertension therapy exerts a favorable cardiovascular risk reduction. The largest study include the total 19,000 hypertensive patients, and average follow-up was 6.3 years. And an ambulatory blood pressure measurement was performed for 48 hours to collect the data on how the blood pressure differed during the sleep. So the RR reduction for cardiovascular event was significantly improved for nighttime treatment when compared with the awakening treatment. Also, we know that the majority of the risk factor that occurred in the early morning, and that's why it is also advised that if a single antihypertensive is prescribed, then it should be taken in the afternoon or in the evening, so that there will be better control of the night blood pressure, and also there will be the reduction in the myocardial infarction as well as the stroke risk. So with that, I am concluding, and thank you.